attention.
Muchísimas gracias, doctor.
Thank you very much, Dr. Esparza. It has really been a very interesting overview of the history of pandemics, where we showed us the differences between mortality curves and mitigation curves. I'm sure that there will be many questions and contributions during the discussion. Continuing with our agenda, we will now start the panel discussion. And we will be addressing this issue with the various representatives of the countries. We have colleagues that are very experienced in immunization programs and regionally and locally. Among them, we have Dr. Alba María Ropero, advisor for PAHO, and we will begin the panel with her. We also have as participants other colleagues from Argentina, Dr. We have Dr. María Ticona from Costa Rica, Dr. Roberto from Honduras, Dr. Berenice Molina from Colombia, Dr. José Mojica, and from Peru, Dr. María Ticona. So I'm sure that there will be various perspectives and situations addressing how the impact of the pandemic of COVID-19 has impacted immunization programs. I am also interested in sharing and discussing not only the regular immunization programs for children, but also um, as program campaigns, but other target groups that in our region of the Americas, we have been able to progressively incorporate, such as pregnant women and vaccines, also HPV vaccine and pertussis. We will begin with the first panelist, which is Dr. Alba María Ropero, Regional Advisor of the Department of Immunization, Integral Immunization for Families, and she will give us a global overview of the regional situation, and then we will address each country individually. Dr. Alba María, please. Thank you, Anna. Good afternoon to all. It is a real pleasure to see you and to take part of this panel with all of you, especially after the fascinating presentation by Dr. Esparza. Now we will um, continue with the reality check of what's happening in our countries. I will rapidly describe the impact of COVID, to go back, closing some gaps and also some priorities, and then the discussion with all of you. Next, please. We know that immunization programs have been negatively affected by the COVID pandemic, and we know that there is an important disruption of the services, the routine services, as with the campaigns that were decreased in most cases. There has been a decrease in the access to healthcare services given the social distancing measures and also transportation restriction, and also the concern about from the families and healthcare workers about the exposure to the virus that led to great fear, particularly at the beginning. We've also had interruptions of the supply chain, and we know, of course, that all these delays in the immunization programs affect especially populations that were already suffering inequities and had less access to services. Here we see a survey showing how this interruption of the services was per region. In the left panel, you see in the first row Africa, the second one shows PAHO, and there were interruptions in May of about 75% in healthcare services, and also a 75% in extramural activities. There were some regions that had suffered a partial closure. We at PAHO did not suffer a complete lockdown. We just have had some disruptions, but not complete interruption. Next slide, please. Sorry, but there's a change in the slide. I'm afraid. I can explain it, however. The idea of this graph was to show the impact on immunization and other essential services such as maternal neonatal health and child health. So here we see that there was an important impact in 67% reduction in prenatal checkups and family planning. Another important disruption is a decrease in maternal care. And this is important because it also affected immunization of these pregnant women. And here we had a 60% reduction in institutional vaccination and 70% in the extramural immunization services. I wanted to compare this with the essential services and immunization as a critical essential service, essential for primary care and for our population. But this calls our attention on the decrease of prenatal care.
Bueno, hubo realmente una desconfiguración, pero está muy bien.
Sorry, but there's some change in the display of the slide. This shows the influenza in pregnant women. I want to mention a positive note in the Americas. 33 countries in the Americas have vaccinated pregnant women against influenza. And if we look at what happened in 2008 before the pandemic of 2009, we only had 7 countries that were immunized in seasonal influenza and in pregnant women. So this was one of the groups of greater vulnerability during the pandemic of 2009. The countries learned that this is a risk, and they learned they had to immunize against influenza, introducing the vaccine for seasonal influenza. That was an achievement which was quite important if you compare to other regions. I have to say that this shows that we have high coverage rates in many countries, but we have a lot to improve and a lot to improve as to reporting in order to have an adequate overview of the coverage rate in the region. If these populations do not achieve optimal coverages, and of course now there are more affected due to the pandemic. And this is for pertussis. We have 17 countries with immunization policies. Another important achievement, pertussis coverage in pregnant women with important coverage rates in some countries, but a lot to improve in this area as well. As to other vaccines in children, we see that there was a decrease, and we've monitored that closely. DPT1 and 3 and measles have shown a decrease up to 20% coverage compared to the previous year. The map shows the campaigns that had been scheduled and those that were discontinued. We had discontinued some measles campaigns. We had some yellow fever that were postponed. Here, this is now being reinstated. How can we come back to the normal situation? We have to make a collective effort because the challenge goes beyond the immunization programs and it goes beyond the healthcare systems. We know that they have huge implications for all society. So we need to try to come back and go to a better position than the one we had before, because we know that in spite of the challenges, acknowledged as an essential service. This slide from Ethiopia shows the measles campaign that have been scheduled for this year and what happened before the pandemic and now what they are doing or the impact. We see that now, after COVID, we have to work more in a different approach for healthcare training of the healthcare personnel. We also need to insist on social distancing measures and PPEs. The cost that additional personnel implies because we need to screen people that come for immunization. This means also additional days. So if they could finish a campaign in 7 days, they now have to provide for 3 more days, as well as the costs. So you see that the situation has changed with regards to the activities that need to be carried out. I would also like to share with you some estimations that the WHO has made about the cost entailed by these activities. For instance, we need to add the hand washing area that adds up to 14% cost, and the other measures, because of course we need to consider the cost of PPEs. All this is new to us, and of course it affects the immunization budget. You need to be considered. So there's a range of about 20% or more as to the estimation of cost for outreach activities. We have also learned in the region with the experience and influenza vaccination, more than 100 million people have been vaccinated in the Southern Hemisphere. And although we had restrictions, the recommendation was made to proceed with vaccination of older adults, people with comorbid conditions, with the goal of avoiding co-circulation of viruses and also the burden due to seasonal influenza on the healthcare services, so that COVID could be focused on. So the countries were quickly prepared to hold these vaccination campaigns with important coordination, and they even anticipated the campaigns in Brazil and Argentina in several weeks. They anticipated the the campaigns as compared to prior years. That meant a lot of commitment and effort and involvement of many actors. The countries also developed innovative approaches, as you can see in the picture, the drive-through vaccination, so that a person should not leave the car to get immunized. And they also used other economic incentives to capture the older adults that were going to the banks. Maybe they had to go to the bank for other reasons, for instance, Salvador or Bolivia. And so at the banks where they were going to collect their bonus, they would get immunized. Those were the strategies that the countries developed in order to be able to attain the goal during the campaign. Second, the next one, please. So we see that with the pandemic, there were opportunities not only for immunization, but for other primary care services. We would like to take the opportunity in the Americas in order to integrate other activities, including the area of generating trust in vaccination programs in those countries. And also we wanted to see the integration opportunities and close gaps faster, not only for immunization, but also for other diseases.
The OMS has developed several guidelines so as to define or prioritize immunization as a core health service, maintain the ongoing routine immunization delivery also, catch-up guidelines, and we are also developing some guidelines for planning and implementing all this catch-up vaccination in order to solve the gaps. They also created a framework for decision-making, perform a risk analysis based in the different disease, and to assess the risk of outbreaks and how to perform campaigns in a safe fashion, protecting communities and health personnel. Just to mention now, we have discussed in depth this other topic, the importance of trust in vaccines. And we see that we have several surveys and studies that talk about the acceptance of the vaccines. And in the Americas, in some countries, the acceptation of the vaccine has decreased a little bit, but it's a little bit higher than Europe and the United States. And to wrap up then, please remember that these are the priorities in the context of the COVID-19 pandemic. There must be a country-focused response. The country is the one that coordinates this interinstitutional work, because we have many, many partners working and acting within this pandemic, so there must be an interinstitutional coordination. We talked about the importance of communication and to prepare key messages for the different types of audiences, so that this promotes the culture of vaccination and generates trusts in vaccines so that we can close the immunologic gaps. It is important to have the end-tax engagement, and we must have managing political and strategic. We must learn how to manage the political and strategic risks. We must be very intelligent to do this in order to face the problems. And we have backslided in a way, but only this is to leap forward. So I would like to invite you all to work together, to share experiences, and to work a better program and to face the pandemic and work to strengthen vaccination. Thank you very much. Ana?
Muchas gracias, Ana María.
Thank you very much, Ana Maria. It's a very interesting national regional program. The impact of the pandemic is very widespread, and this gives us many challenges to face now. Now we go to Argentina, where Dr. Maria Masinovich is going to tell about the experience in Argentina. She's a pediatrician, and she is part of the specific area of disease control. Maria. Thank you very much. Good afternoon. I am not Carla Vizzotti, as it says here on the legend. I apologize because Dr. Vizzotti is busy, and I would like to share a summary with you, a summary that we prepared about the situation in our country and the important points that we draw from this analysis. Next slide. As we presumably all agree, the pandemic has come to change our immunization programs. We could say that before the pandemic, the program in Argentina was growing and growing in a sustainable and fashion, and during the last month of 2019, we've had some important changes related with the rebuilding of our ministry and the new policies that we've adopted in order to prevent and protect in health. On March the 3rd, we had the first COVID-19 case in our country, and As from then onwards, we can say that our reality changed because we had to reprogram all the circuits of supplies for immunizations, for example, of anti-flu vaccine or influenza vaccine. We had to reorganize the whole staff, the whole human resources staff that are working in health. And in many cases, we had to adapt the personnel, the staff that we have, which is sometimes short for us, on the new tasks that were new for the health personnel, the one in charge of giving the directions and the decision making also. So it was an abrupt change, and it came hand in hand with more physical resources and financial resources. We also had to learn how to work in a different way and adapt our life to new working modalities that had well to do with a greater workload in our functions and in our work. And we had to understand how to train our people, how to communicate, or to the redo in the remote modes of working, which before only represented a very small percentage, but we had to start working in the post-pandemic period, meaning how are we going to plan our actions for the moment when the new normality comes. We all know that these have not been. We understand that all the strategies in public health have been impacted, so we will have to recover and improve them. The program, the immunization program in Argentina, as in the rest of the countries from our region, has 5 pillars, which means that they are free, the supply, they are mandatory for our inhabitants. This prevalence of these public policies above others, the availability of vaccines and vaccination departments, and the joint participation of all the health systems. So these pillars allows us to have a comprehensive immunization program that implies more numbers of vaccines applied within the program, but also more rights and obligations in our case as from the first immunization law that was passed in 1983 and then was modified in 2018, but based on the same basic pillars. With the pandemic, as you all know, in Argentina, as in other countries, a lockdown was established 17 days after we had the first case in our country. So this was an extraordinary measure and taken really early in time. After this lockdown started, there have been several modifications so that we could adapt this lockdown to our reality. But before the lockdown started on March 12th, an sanitary emergency was established. So, in spite of having vaccines for free and that they were mandatory prior to the lockdown, that we knew that was going to go against the access to vaccination, we established the sanitary emergency, and we knew that the immunization calendar would suffer modifications. Going now to the vaccines. A very important case is the influenza vaccine in our country. We bought in 2019, in 2018, and previous years a great supply of influenza doses. We have 7 or 8 millions of elderly population that need this type of vaccination, but we had 2 millions extra of vaccines. This is one of the things that we've started doing during the pandemic. As the pandemic was declared and as we had more doses, we started applying the influenza vaccines. And as you see in this graph, green is 2019 and violet is 2020 onwards. In 2019, the doses given to the health personnel were 520,000, and this year we went up to 1,500,000 doses of vaccines. So, as it probably happened in some other parts of the world, there was more demand. And this is something that we must work on so as to maintain or to improve in the next years. In elderly patients, we do hope to see a change because it was a population that had been receiving the vaccines in a continuous fashion. And during this year and under the pandemic, we could apply the same amount of doses, but being under the lockdown. So this is really great. This is one of the best achievements, I think, because with the pandemic, our winter immunization campaign was moved forward. It was advanced in time. So we started applying the immunizations 1 month earlier. So what we are comparing now is the amount of applied doses since we started the campaign. Applied doses to the elderly population were duplicated when compared to 2019. We vaccinated 1,200,000 people more than in 2019 because there was a good campaign, a good promotion of this vaccine, and it was very targeted to this population that needed the vaccination. And then the group from 2 to 64 years with comorbidities, which is a complex group, they also increased the number of doses received. So we were successful in this sense. We were able to increase the amount of doses in all of the groups. And this had to do with the COVID pandemic, but also with the good information and the promotion campaign that we did. And now we need to maintain this situation for the following years. Let's talk about our immunization calendar. And now we are going to compare the vaccines between the first 6 months of 2019 and first month from 2020. And I would like to tell you about our registry for vaccination. the vaccines from 2019 are those vaccines that were uploaded in the registry throughout the whole year. But what you see in the violet bars are those doses from the first 6 months of 2020. So by the end of 2020, as we have this delay in the uploading of the data, the vaccines applied in 2020 will be higher than those applied in 2019. But see, not even for 2019, during the first 6 months, we could reach the 50% needed or required. Argentina is not suffering a decrease in vaccination now. Argentina has a decrease in the coverage throughout the last years in an unfortunate sustained fashion, and this generates a lot of worries, and this worsened during the pandemic. So the challenge that we have now is not only to overcome the pandemic, but also to have the same coverage in terms of vaccinations as we had 5 years before. We selected the polio vaccine and the pentavalent vaccine here to show and share. Must I go back to the panel? So the doses given to infants are IPV for 2020 and OPV and IPV for 2019. Though in 2019 we did not reach the 50% required for vaccination, during the 2020 we see a drop of between 6 and 9%. Also, in infants below 1 year of age, the coverage reduced from 47 to 37%. For children 5 years and above, and talking about the MMR, the vaccination schemes suffered a reduction of almost 10%. And if we then assess the adolescents, besides a difference between 2019 and 2020, unfortunately, we have a delay between the first and the second dose of the HPV vaccine. And in pregnant women, there is also a decrease in the anti-influenza vaccine and also of the AAA cellular vaccine. It is important to mention that there is also a decrease in health control for pregnant women and also after delivery, and also in health control of the newborns. Everything, all of this due to the pandemic. But good things also happened. We achieved to control this measles outbreak. We in Argentina are measles free, and this has to do to the effort of the immunization task force. So one of the things that we could say is that in spite of the pandemic, in spite of the COVID-19, we are not having a decrease in quality, because working tirelessly, we can still achieve these sort of things. Just to wrap up now, some general aspects that we've been working on. Next slide. Next slide, please. Next slide. We've been working in innovation, in using different tactics of strategy for vaccination that weren't used before in the past, as, for example, to outreach our population, to get vaccination on open air, open spaces, to vaccinate our health personnel first, taking care of our health personnel, and we have been vaccinated in clubs, in churches, in civil associations, in schools that are now closed due to the lockdown are being used as secondary places and as safe places for vaccination. So we've been working a lot in the outreach on social media, and we have had the key support of all the scientific societies that are responsible for vaccinations, and also we have had a huge support from our scientific community. And we have developed these communication tools from the beginning of the lockdown to work not only on vaccination for the winter season. We first vaccinated elderly population and health personnel. Then we vaccinated pregnant women and children, and then groups that had risk factors. The second tool had to do with the strategies of vaccination according to our calendar and the strategies according to the social distances needed or the isolation needed in each of the municipalities. And the third pillar had to do with vaccination of people that had suffered from COVID. And last but not least, we want to have a profound transformation and change these challenges into opportunities. We have been working in order to obtain political commitment from all the society levels. We wanted to update our immunization calendar. We wanted to keep on vaccinated. The vaccination sites were never closed in spite of the lockdown. We had a very successful winter season. We were able to close the measles outbreak. We could work among the ministries, for example, health and education. We created a new national commission on immunizations, and we started planning all the activities for the time after the pandemic. Thank you very much. Thank you for having me. Thank you, Dr. Marina. I would like to ask the rest of the panelists to have their presentation for 10 minutes only. We will continue with Dr. Arroba, who's the Chief National Immunizations Program Coordinator, part of the Ministry of Health. You have the floor.
Thank you, Dr.Morice. Very kind, and good afternoon, everyone. I will present the data regarding Costa Rica for this year. In contrast with Argentina, I showed vaccination coverage until the month of August 2020, and I carried out a projection. If everything would continue similarly, how we would end the year in our country. This briefly shows the official regimen of immunization for Costa Rica. We have one of the more complete regimens of the region with new vaccines. For instance, in IPV, we don't have oral polio since 2011. We have varicella, and recently we have introduced the HPV vaccine in children as of last year. This shows the situation until present in Costa Rica. Costa Rica. In blue bars, we see the month of August. If you look at BCG, there's a coverage until August of 55%. And if everything would remain the same, the projection would be to reach a coverage of 83%. However, here I'd like to note that we estimate the coverages based on official births reported by INEC, and hence this is under the hypothesis that 68,000 children will be born this year as were born last year. Probably the births, if the number of births decrease, the coverage rate would increase. With regards to the pentavalent IPV vaccine, we have a coverage rate of a first dose with 58%, and if everything would remain the same, we would reach a coverage of 87%. As to rotavirus vaccine, we have a 59% coverage until August, and we hope to achieve 89% by the end of the year. And as to pentavalent 3, if you look at the coverage was 62% by August, and we estimate that if everything would remain the same, we would reach 93% in coverage. And finally, regarding vaccination in infants less than 1 year, hepatitis B vaccine third dose reached a coverage of 63%. With similar circumstances, we would reach 95% by the end of the year. What I did not mention was pneumococcus, where we had a coverage of 61 and we would reach a 92%. As in the other slide, the one you're seeing now, this shows vaccines administered to children older than 1 year, and as the case of measles vaccine and pertussis, and mumps vaccine. We hope to reach 97% by the end of the year. In the case of the varicella vaccine, administered at 15 months, that was 67% coverage by August, and we would reach 100% at the end of the year. The other vaccine shown here is the influenza vaccine, and this is specifically for pregnant women. What was administered this year was what corresponded to 47% among the population of pregnant women in our country. As to the TDAP, which is also administered during pregnancy, we reached 58% and we hope to achieve 86%. We also have to mention vaccination against seasonal influenza in our country. Usually we take 10 to 12 weeks for that. And this year, because of COVID, in 4 weeks, almost 5 weeks, we had administered 100% of the vaccine. In Costa Rica, we acquired 1,300,000 doses, 200,000 for children, and 1,100,000 for the adult population. Interestingly, a great number of the population that usually does not get immunized did so, and that led to a very successful campaign in such a short period of time. I also mentioned, Alba Maria mentioned, the issue of COVID and its effects. It, of course, led to closure of airports and difficulty in receiving the vaccines. Supplies were missing. We had an important stockpile, but in spite of that, at least a couple of vaccines were not received in time to complete the regimens until the country opened airports in June, July. And we did receive commercial flights, especially those that were carrying cargo, and so the vaccines eventually entered the country. So, like I was asked to take just a short time, this is all the information I have on Costa Rica. Thank you, doctor. I give you the floor again. Thank you very much for staying within your allotted time so that we can stay within our schedule. And we will now continue with the next presentation by Dr. Berenice Molina, who is a veteran in the immunization program since the beginning of the 90s. She's in charge of the immunization program in Honduras, so she has a vast experience that she will share it with us. Ida Berenice, you have the floor. Good afternoon, Dr. Maurice and dear colleagues. I will be presenting the impact that we've seen of the COVID pandemic in with regards to the vaccination coverage for routine regimens and the annual campaign that's carried out in our country. As to the immunization against seasonal influenza in our country, we carry out an annual campaign in May of each year. And this year, due to the COVID pandemic, this was rescheduled for the month of June. As you can see, related the various groups, if we compare coverage achieved in 2019 with 2020, we see that there was a decrease in immunization coverages in most of the groups at risk: healthcare workers, children aged 6 to 23 months, adults older than 60, and farm workers. The pandemic continues, and the campaign coincided with the beginning of the larger number of COVID cases in our country. That's why the coverage rates were affected. As to the vaccination of pregnant women, the pregnant women that received TDTAP, and this is administered not at a national level, but rather focused in areas with greater concentration of population in the metropolitan region. And the influenza vaccine is given to pregnant women during campaigns. And generally, we see that the pandemic has had an impact in the vaccination coverage in pregnant women. Therefore, this was significant, especially the vaccine against seasonal influenza, where we achieved 85% in 2019 and only 60% for 2020, with a decrease of 25% in coverage, which is really significant. I also want to share the situation of vaccination in adolescents with HPV vaccine. In our country, we administer vaccines to 11-year-old girls, and although there was a decreasing trend in vaccination levels during that period, 2018-2019, for the first doses, by August 2020, these coverage rates, we would like to achieve by the end of the year rates, but they will be less than 2019. The main strategy of vaccination is carried out in educational centers, and of course, those have been closed down since the beginning of the pandemic. And schools have been closed for 6 to 7 months, and they continue to be closed. Therefore, it's a great challenge that we can actually capture this population at a national level. Generally, if we summarize the impact of the COVID pandemic and on all the vaccines administered, we see in this graph the analysis of vaccination coverages from January to August 2019 as compared to the coverages rates from January to August 2020. And we can see that there has been a decrease in vaccination coverages as compared to 2019. In the case of children younger than 1 year, the decrease is 4% for BCG to 7% for the rest of vaccines administered to this age group: polio, rotavirus, pneumococcus, pentavalent. This decrease is significant. In the group of 1 year, the decrease has been 7 to 8% for hepatitis A, for the first doses of measles, for the first booster of polio, and BCG. In the group of 4 years, the decrease has been 4%, And in the case of 11-year-old girls who receive the HPV vaccine and the boosters, we see that the decrease has varied from 4% to 12% drop. And in the group of pregnant women, this has been the group that has been most affected by the pandemic and the decrease in coverage rates. However, it's important to underscore that if all the interventions that were carried out would have not been implemented, and if we would not have had the commitment, the political commitment and the commitment of the healthcare workers, um, keeping immunizations in the technical and political agendas, then the drop in coverage would have been greater. And it's important to acknowledge that these interventions have allowed vaccination coverages in children have been above 80%. There have been many limiting factors, and I would like to mention some. First, the measures of social distancing that were implemented in the country with restriction to population mobility. These have not been removed at national level. The lack of public transportation that hindered the mobilization of the population, also the fear of the population of contagion. COVID-19 has limited the demand for vaccination services. Uh, Scarce outreach vaccination by the healthcare personnel. Some of the medical institutions and healthcare institutions have been closed, maybe because the personnel that administers vaccines is older than 60 years old or has chronic diseases. There was late uh, supply of PPEs in personnel, and some of the nurses and auxiliary personnel have become ill with COVID-19. And also there was limited dissemination of services available for the population at the beginning of the pandemic. Also, the transportation logistics at the regional level prioritize the support of COVID-19 actions. The lack of financing to be able to sustain the promotion of vaccination by the media. The campaign of vaccination was usually done in June, and there was low, there was a drop in the financial resources as well. The main interventions then have to be mentioned in order to try to maintain vaccination coverage and to overcome this great challenge that we're now facing in all countries. First, meetings of the National Consultative Committee for Immunizations to provide recommendations regarding the situation, periodic newsletters at a national level with the national guidelines about the functioning of the program, of immunization program. I think this is important, and among the interventions, we need to mention this as successful intervention. When you provide timely guidelines to all the healthcare personnel, that is important because it establishes a clear stewardship on the healthcare guidelines. We also have to achieve associations and alliances. We have to provide PPE for all the personnel that is involved in vaccination, pediatricians, and etc. We also use of the social media, vaccination in with protection measures that were appropriate. There's also the issue of strategies and tactics of vaccination that were um, provided at the municipal level according to the epidemiological behavior of COVID. There were some municipalities at the time that did not have any cases, and there the interventions were different from other municipalities where maybe there were a high number of cases. The relocation of the vaccination services outside healthcare establishment or facilities such as schools or community centers, and other interventions were to integrate vaccination to the rapid response teams and the brigades acting in the community. This was carried out at a national level in the various neighborhoods in the large cities and municipalities of our municipalities in the country. Besides other interventions, we intervened with medical societies and implemented a promotional campaign at the national level. And the idea was to have implementation and strengthening of the immunization plan. And the last one was to implement a shortened vaccination regimen for population below 1 year of age and aged 1 to 4 years that have an incomplete regimen according to our guidelines. This completes my presentation, and thank you for your attention. Thank you, Dr. Molina. We will now continue with the representative of Colombia, Dr. Jose Mojica, pediatric infectologist of the National Immunization Program. He works in communicable diseases of the Ministry of Health of Colombia. Alejandro, you have the floor.
Thank you very much for the invitation. Thank you very much, Dr.Morice and colleagues. In this presentation, I would like to share with you the situation that we have in Colombia. We have 21 biologicals for 26 diseases. We have the active programs of immunization, which is one of the most important for us for prevention and promotion. See, this is a coverage throughout the last year, but as from newborns with the BCG, we want to have 50% of what expected, and BCG with Hep B hepatitis, we're below the desired 60%. At 1 year, 50% have the MMR, and we should be higher than that. And varicella is not included here. We are near 50%, and the DPT8 for pregnant women, we are in 42%. As you can see, all of our figures are between 50 to 63%, and we should be a little bit higher. And this gives us an idea about the traces. Next slide, please. With the traces, we see that we should be above 63, 64%. But if we take into account the pentavalent vaccine, in 2018 and 2019, we have a 63% coverage. And this year, with the pandemic, is 50%. Then, as we analyze the MMR for us, this is key because we started the outbreak in 2018. Back then, we had 95% coverage at 1 year for MMR, and 2019, 95%. But this year, we are 22% below that we had expected. And in figures, what you see below 2018, 2019, and 2020, see the drop that we have in the amount of children that have been vaccinated, and they turn to be susceptible then. Take a look at the tracers. Pentavalent drops, MMR drops, and the booster at 18 months also drops. If we then take a look at the MMR, well, at 5 years, where we include all the boosters, see, we have also a drop with a fall of about 65,000 children that are left unvaccinated. These were the coverages 2018, 2019 of these traces, and this is what we expect for 2020. there is a marked drop in all of the traces, reaching up to 74% at the most, or 75% at the most. This next slide shows how our country will behave with regards BCG, pentavalent, MMR, and MMR at 5 years of age. This would be by December 2020. We should be at least at 90% coverage, or hopefully 95, but we are below that. So this is our reality. This is what we are having now with the pandemic of the 2020. Next slide. This is really worrisome. For July, this is until July, and we've started with the children vaccination. We have only of girls at 9 and 17 years, but we had the best coverages when we had 3 doses. That was back then in 2012. Then we have the Carmen de Bolívar, which was an incident where we had a huge collective anxiety, and these programs disappeared, and we reached coverage of 6% in 2016. Then the coverages rose up to 35% with the first dose, and nowadays we have 15% coverage for the first dose and 5% coverage for the second dose, and this coverage should be above 90%. This is really worrisome. So the VPH is one of our challenges. Talking about seasonal influenza in the framework of the pandemic, we have two epidemiologic peaks. Next slide. Next slide. I want to show you that we have the two peaks for the influenza in our country, one that starts in May until July on the rainy season, and the second one that starts in September until December. During the first semester, we assessed two peaks, and with the lockdown, we wanted to stress vaccination in children. First dose is 80% coverage, but in the second dose, we have 42%. So this is a real challenge for us. And then when we analyze on the right-hand side the second dose, we are in red, meaning that there is an important drop. During the first year, children that require only one dose have received the vaccinations. But then when we analyze the pregnant women, the coverage is 74% in that group. And then when we analyze the elderly population, the coverage for them, we wanted to achieve 2 million vaccinations, and we are below that figure. We only have 36% coverage. And what about people with the comorbidities or with risk? We didn't achieve what we've expected. So we are far behind talking about elderly population, talking about underlying comorbidities and pregnant women and all those infants that require the second dose. Next slide. So we did a lot during this pandemic, but we're reading the general guidelines in the extended immunization program. The first print came out in March 2020, and we follow the guidelines of the WHO, of the PAHO. We modified some guidelines from the Ministry of Health, and this is to have everybody vaccinated. Then we included priority groups. We required more doses of vaccines, including the influenza. However, when we had to organize the application of the vaccines, waiting, social distancing, triage, the intramural vaccinations, that was a challenge. We had to face difficulties. People didn't come to consultation due to the lockdown. There was a need of social distancing, and this implied like a double message: stay at home, but at the same time, come and receive your vaccine. So we had to create different ways or adopt different ways of vaccinating our population. We had limited availability of our health professionals. So at the moment, we have 15,000 health uh, professionals that are infected with COVID-19. So there was a fear in the community to come to the vaccination centers. They didn't want to go out with their kids. The health professionals had they still face the challenge of this myth according with regards to the influenza vaccination. We didn't have enough human resources in order to cover our strategy of extramural vaccination. There was fake information with regards to safety of the vaccination, and people were afraid of getting infected, and it is difficult to go to the distant areas in our country, for example, the rural areas. In the next slide, we see all the successful
Alejandro, disculpa,
measures adopted.
tenés 2 minutos. Tenés solamente 2 minutos.
We've integrated the primary attention with surveillance. We had social media with it, campaigns on radios, scientific societies uh, supported us, the infectology associations, pediatric associations. They all supported us and helped us in the outreaching of these programs. We've articulated and worked with other universities and associations. We created mobile areas for vaccination. We had a plan which is called Get Your Vaccine in Your Neighborhood. We have a nominal system. We can locate our susceptible populations and perform the outreach of our susceptible populations. We are identifying the elderly patients and we go home by home vaccinating the people that need. And this is our strategic plan. In September, October, and November, we want to achieve greater coverage for vaccines, performing a sort of extended immunization plans with extramural actions with mobile units house per house, following the kids and performing an update of the immunization medical records of each of our children, and thus trying to reduce the number of susceptible patients. These are the guidelines, and this is the campaign that we created. We've started on September 26th, and then we have symposiums in October and November. And the last slide, the last take-home message, we need to manage this. We need to have an extended immunization program at a national, regional, national level. We need allies, scientific societies, the academia. We need human resources. We need to have vaccinators and supervisors. It's difficult to have an effective outreach to the outer parts of our country. We must perform calculations of the supplies that we need. We must achieve local distribution. We were able to vaccinate against measles, and we must control this outbreak. We are an update in yellow fever. We've started with injected polio vaccines at 2, 4, and 6 months. We must strengthen all the coverage because this is one of our challenges, and we must get prepared to what we are going to face after the COVID pandemic. Last slide is vaccination happens every day. It is free. Please do it right away. Every child below 5 years of age must receive its vaccines, and they know that they must go 8 times to the vaccination sites to receive their vaccines. Thank you very much.
Okay, muchas gracias, José Alejandro. Y para concluir,
Thank you very much, José Alejandro. Now we are going to hear Peru
María Ticona, que es la directora ejecutiva del
with
programa de
María
comunicaciones del Ministerio de
Ticona.
Salud de Perú. Adelante, doctora María.
She is the one in charge in Peru.
fíjese si tiene el micrófono.
I don't know if your mic is on because we cannot hear you.
Debe tener el micrófono en mute. Fíjese abajo.
Are you muted?
Intente nuevamente, por favor.
Buenas tardes, ¿ahora cómo se me escucha?
Good afternoon. Can you hear me?
Buenas tardes.
Good afternoon.
Sí se escucha, adelante, continúe, por favor.
Bueno, buenas tardes con todos. En primer lugar, la invitación.
Good afternoon. Thank you for the invitation. I would like to greet you all from the different regions of the America. I am going to tell you about our vaccination coverage during the COVID pandemic. The immunization coverage have decreased given the lockdown that we needed to establish to protect our citizens. So all the vaccination strategies have been postponed in order to be able to comply with the social isolation. So there was a partial confinement at the beginning where they were only given administrative vaccines to the newborns. For us, it was really difficult to reconvene with the vaccination activities. And we also have another problem, because between 30 to 40% of our human resources are within the risk groups. So this makes vaccination even more difficult because there is a shortage of nurses, for example. We have a very limited human resource and also a limited budget. There is a demand by the population to get their vaccines. They want to get vaccinated. So for that, we passed an executive order where we allowed the different national directions to implement measures in order to execute this sort of catch-up plan that we needed for the immunizations, and this was approved by the end of June. In this executive act, we have approved a budget so that the vaccines could go to the different parts in our country where they were needed. We are now achieving to close the different gaps and performing an adequate catch-up program. We have the National Symposium on Vaccination next week. We will start on the 10th in the national scenario, and then in October and November and December, we are going to have workshops where we're going to vaccinate the elderly population, and on weekends we are going to vaccinate adolescents, children, and pregnant women. We would like to thank all the authorities from the Ministry of Health because they really have a commitment and they give us the support that we need. We're a few days to go to start this symposium, and we are preparing everything to get on with this activity. What is really important about the pandemic is that it has made it mandatory to create in a joint fashion with all the rest of the institutions, with private clinics and hospitals, with local governments, and with the civil associations. Our most important limitation is the limited human resources that we have. And we do think that with all these actions, we are going to be able to decrease the gaps that we have currently. And it is a fact that our vaccination has dropped, vaccination coverage.
This shows the vaccination coverage in a cohort from 2019 to 2020 in younger than 5 years old. In orange, you see there is a decrease in 2020. For instance, I'll just focus on the pentavalent of the 35%, and we should really be in about 66%. There is also great concern, but we are working and we hope to close our gaps, and we need to make an effort. Shows influenza vaccination. The coverage rates in babies less than 1 year and in older adults, we really have still a great number to be immunized in all age groups. In the group of 60 years of age, you see that there's a greater number compared to 2019. Then we actually plan to schedule for 50%. We actually should do it for 100%. So we're trying to change our target for 2021. And similarly, the number of people with comorbidities clearly is very low. This shows immunization against HPV 2019 and 2020 in Peru. As you can see, this is of great concern. We have really decreased in first dose. Currently, we have a 38% coverage. So we have to emphasize that in the midst of the pandemics, the nurses had to immunize because the vaccines were going to expire September 9. So probably we would have had less, even less. So this is a hard work that had to be undertaken by the nurses to administer those vaccines that were next to expiration. We're really worried by our coverage rates. Probably for 2020 won't be able to recover, but what we need to do is to try to capture the young girls in order to capture them at least to catch up in 2021. This shows vaccination in pregnant women with influenza and DTIP. These coverages were a little bit better here, around 27%, but this is also hard work which is reflecting the months of January and February. In 2019, we've really neglected this because we've had The goal there was to recover and vaccinate the pregnant women specifically in order to avoid problems in children younger than 2 months. In pregnant women, clearly the rates are low, and so we are now articulating this with the other components in order to improve these numbers. Immunization strategies. What have we done in this context of the COVID-19? What we have done is to vaccinate in strategic areas and places, either going to people's homes or mobile brigades. All those have been done with prior appointment so that we wouldn't have groups of people and we wanted to avoid having many people together, children with their mothers. We also have used schools and sports clubs and community centers. We've also used targeted immunization in municipalities, looking at the lists of neighbors. We've also worked in the indigenous population and in rural areas, particularly in the eastern areas. This activity is complemented, trying to close gaps with a telephone follow-up. It's proven to us to be a good strategy. And with the phone calls, we orient the mothers and so that the time they have to spend at the vaccination places is really short, and so that is done in order to avoid contagion as well. If there are questions, I'll be happy to answer them. Thank you for your attention. Thank you, Dr. Ticona. Unfortunately, we're running out of time, and I would like to thank Dr. Espasa for his excellent presentation and would like to thank all the colleagues from the Americas and Dr. Ropero for giving us the global overview of the questions that we have received. I think that all presenters were very clear, and there is no question that the pandemic has affected our vaccination program. And it's also quite clear that creative strategies have been adopted in order to at least try to maintain coverage rates. And of the questions that we received, they mainly focus on how the vaccination against COVID will be probably in 2021. So I would like to close with that observation. We have challenges and the delays and the difficulties and requirements of greater resources and new strategies that 2020 has posed for us. We probably have had cha- um, um, decrease in surveillance, a subject that we haven't touched on, but if we analyze that, I'm sure that's going to have an impact because of under reporting, and we probably have to recover those surveillance programs. And we also have the great expectation and hope we can have vaccines against COVID-19 in 2021. So this probably will comprise the next few years and will mean a lot of challenges and work for us. But I do believe that with all the strategies and innovations that we are undertaking in programs and looking for the target populations, I hope it will be possible to achieve this. I would like to conclude saying that this has been a difficult experience, but the good practices that have been implemented by the various countries have to be useful not only to recover a coverage rate, but also to be able to strengthen the immunization program and epidemiological surveillance in the years to come. Thank you very much to all
y mucha suerte
participants, and
con todo el
I
trabajo
wish
que
you
tienen por
good
delante.
fortune with all the work that you have ahead.